So my name is Bianca Buijck. I'm the Managing Director of the Rotterdam Stroke Service in the Netherlands. And the Rotterdam Stroke Service is a collaboration of 17 organizations providing care to people with stroke. Those 17 organizations are hospitals and rehabilitation centers, and also community nurses, community healthcare workers.
If I understand correctly, here in the Netherlands, just like in the United States, historically, the services of the different providers in the stroke network would have been paid fee for service.
Yes.
Can you talk a little bit about, as we now have this attention toward value, what does value mean to you in the stroke network?
Mostly value for the patients, I guess. So the value we can deliver in healthcare to the patients, helping them to cope with their inabilities after stroke, treat them for their stroke, so we can offer them a better quality of life. So that's value for us in the stroke service, so from a professional's perspective.
So when you came together and realized you needed a different approach to improving the value provided from the system of all the providers together, how did you go about defining what the best outcomes would be like and designing the model?
The Rotterdam Stroke Service was founded in 1997, so we're here for 24 years. We have a difficult payment system in the Netherlands, so it's very complicated. Hospitals are paid for service, but it's another payment system for hospitals than for rehabilitation. Then we have two kinds of rehabilitation. We have the medical rehabilitation, we have geriatric rehabilitation, two different payment systems. And then we have the community nurses, that's another payment system. And then we have the community professionals like physical therapists and occupational therapists, that's a different system. And then we have the municipality care, they can give care also, that's another system. So there are a lot of payment systems in the Netherlands and we are not able to substitute them. So patient goes to a hospital, then he receives his care, then there's a payment system behind it, then he goes to rehabilitation, then another payment system starts. But you cannot say, okay, let's do patient admission in hospital for 3 days instead of 5 days, and then we just take the money and we just see how it goes. We cannot do that because one payment system has to open and close, and then the other system has to open and close, and you cannot send a patient to another facility if the payment system hasn't been closed. Does that make sense to you?
I understand what you mean, but it doesn't make any sense at all.
It doesn't make sense.
So what problem were you trying to solve? Was it the unnecessary complexity of the payment flows or any other issues around quality patient or family experiences, or what?
Because we are here from 1997, we have, I think, a proper quality of care for stroke patients. I think we did it all right. And going from 8 to a 9, or 80% to 90% of quality, I think that's rather a challenge. But we were not supported by the payment system. So the payment system was a challenge for us because I can give an example. We have two kinds of rehabilitation, medical rehabilitation and geriatric rehabilitation. And the medical rehabilitation is a high pace of rehabilitation. So you get training for 9 hours a day. And we have geriatric rehabilitation, and it's about 2 hours training a day. So the geriatric rehabilitation is mostly for older people. The medical rehabilitation mostly for younger people. And age is not independent determinant because you have older patients who are very fit and go on cycling, so they can go to medical rehabilitation, and we have younger patients with, for example, COPD, they go to geriatric rehabilitation because they cannot have a high pace of rehabilitation. So in case of a younger patient in triage, you say, younger patient, you can go to medical rehabilitation. But he's not fit and he has a lot of disabilities and maybe he's not ready for the medical rehabilitation. Then you will think, okay, we do into geriatric rehabilitation, start with that for a month and have a low pace of rehabilitation, and then we can transfer him to the medical rehabilitation. But that's not possible. That gives issues because you have to close one payment system and go to another, and that's very complicated in the Netherlands. So we thought if we have another payment system, maybe we can overcome that kind of challenges.
So that helps me understand the problem you're trying to solve. That's great. Can you talk through what the new model looks like?
Yeah, we have a bundle payment. So we have 4 organizations in the Rotterdam Stroke Service, so 4 from the 17, and 1 healthcare insurer. We started a project. And in the project, we agreed on bundle payments. So we get a bundle of money per patient. And for the clinical phase, we use that bundle. So if a patient needs hospital, he's going to the hospital takes out of that bundle, the rehabilitation takes out of that bundle. So it's a population-based payment system.
So can you elaborate a little more detail about what all is included in the bundle? And if you think about the patient's pathway from initially having the stroke until some long future point, what are the bounds that include the bundle? Like when does it start clicking, and then when is it done?
Yeah, I think that's everything in the care path. So from admission to the hospital and everything in there, from treatment and guiding and to the end of the rehabilitation phase. We only took in the bundle now in the agreements the clinical phase. So not when patients are going back to the community. So that's a boundary for now.
So the specialist services are included?
Yeah.
Imaging, labs?
Everything, yeah,
included.
yeah,
Okay.
It does.
So when you talk about them going back into community, can you explain that a little bit more? What's not covered?
Not covered, nursing help in the community, help from the municipality, no physical therapists, occupational therapists, psychologists when they are living in the community at home. So that's a boundary.
Okay, so as soon as they leave a rehab center, a facility.
As soon as they leave the center, they're out of the bundle.
Okay.
But our contract is ending this year, so we had a 3-year contract. So now we're looking at a new contract and looking at involving more healthcare insurers, more organizations, but also the community.
That was what I was going to ask. Why does it need to be rehab in a facility? I could see that could drive the incentive to do the care here because it's being paid and not to do it in the community simply because it's separate. And maybe for a given patient, home rehab would be better and maybe cheaper.
Yeah, it does. And it's not the case that they cannot rehabilitate at home, but then another payment system goes in place. Yeah. So they first are in the bundle and then they go out the bundle and then another payment system is in place.
Right. And the insurer doesn't like that, of course, and I guess from a societal perspective, it's more cost.
Yeah, so what are we planning to do is to put more money in the bundle, so make new agreements to cover it all. Okay. But it's a very complicated project because we look at all the care for the stroke patient. So all the care that is needed for the stroke patient, we take in the bundle. Some projects only have one intervention and they have agreements about payment for one intervention and they steer on one intervention, and we work with everything around the stroke patient.
So I want to hear a little bit more about when you designed the model. How did you and the others who were involved design it this way? Why?
We designed it because we thought the admission processes between organizations was not well designed. So there were hiccups in those processes. And we saw that patients were not always on the right time, on the right place, treated by the right professional. If a patient stays in hospital for, let's say, 14 days, there's a lack of rehabilitation in the hospital. So it's not good for the patient to be in the hospital. If we look years ago, there was not always a place in rehabilitation. So we needed to make agreements with each other about how soon can the patient from hospital be referred to a rehabilitation center. And that's one of the things we thought, The payment system doesn't support that. And now we can say, okay, it's in the benefits of patients and beneficial for us to move the patient from hospital to rehabilitation as soon as possible. If the patient is clinically stable, you have to move them to the rehabilitation center because then rehabilitation can start.
And that's a lower cost environment here.
Lower cost environment, yeah.
Okay. Were there any legal concerns when you shifted away from the old structure? We know the law is sometimes the slowest thing to change. What were the concerns you had to address?
Yeah, we have, how do you say that? I'm not sure how to say that in English. Waakhond is someone who guards the payment systems. It's on a national level. And you cannot communicate your costs or declarations to other healthcare organizations. So that's very complicated if you work together with one bundle. If you don't know what hospital costs are and if you don't know what rehabilitation costs are, you may not talk about it, then it's very difficult to work within one bundle.
So did that require a waiver from that particular regulation, or how did that work? We have the same problem in the US.
Well, we just work around it. So I am not involved in the hospital, I'm not involved in the rehabilitation centers, so I can look at the data, but I cannot communicate with others about that data.
So what does that mean then, that you tell them, oh, no, we need more money because these guys need a little more, with a wink of the eye? Or how do you...
Something like, I can see what is used in the bundle. So I can see from the data from the hospital, I can see from data from the rehabilitation center, and then I put it together and I see, oh, okay, we're in the bundle. We're still in the bundle. Or we're out the bundle. We use out of the bundle.
Were there legal changes to allow you to coordinate more?
No, there were not legal changes because we talked a lot about it with healthcare insurers and with NZA, that's the guard in the Netherlands, and we took them in the process. We communicated in the years about everything we did and we wanted to do.
What about some of the, I'm thinking about information sharing. Do you share an electronic health record or some other mechanism for sharing patient records and data?
No. Data, we share data, but not electronic patient records. That's interesting to talk about because we collect a lot of patient data. So we collect a lot of patient data in hospitals and in the rehabilitation center and the other rehabilitation center and the other rehabilitation. We collect a lot of data. But we don't share it. Normally, we don't share the data. Yeah. For the purpose of this project, we wanted to share it and we wanted to follow the patient in his patient journey. So we needed to know how does one patient does it in hospital and then in rehabilitation, and we need to connect those data. And we were not able because it was not legal to connect those data. We were not able to connect it ourselves. So there's a certified organization in the Netherlands who is able and responsible and legible to do that.
Okay, so that third party, is it governmental or non-governmental?
I guess it's non-governmental, but we call that the third trusted parties in the Netherlands. And so we ask them, Dutch Health Data, DHD, Dutch Health Data, it calls. And they put all the data from all the organizations in one database. Mm-hmm. And they we made a dashboard. I was helping them to create a dashboard. So now we have a dashboard with all the data. Every quarter of a year, all the organizations deliver the data to Dutch Health Data. And then we can analyze everything from costs to patient outcomes to everything.
That's what I wanted to ask. So specialists, the rehab, the geriatric rehab, hospital are all submitting data quarterly to DHD. And then do they automatically send you and all of the stakeholders a quality report, or you query the database?
Yeah, I do that together with someone in the hospital. Yeah.
So can you talk through a little bit about what kind of quality data you get? It helps you know, like the geriatric people maybe need to do a better job. The hospital's doing a great job. How can you learn where there are points of excellence and points of improvement needed?
We have a lot of data from smoking to treatments to medication to laboratory results. You can imagine a lot of it. And we have 3 indicators. We define 3 indicators on quality of life, patients' experiences, and patient outcomes. We had measuring instruments for those 3 indicators. And those 3 indicators, we have a range in which we need to perform. And we need to perform within that range to have the shared savings from the bundle. If we perform worse for the patients, then we have shared losses from the bundle. And we monitor the results on those indicators. In the past 3 years, we are still in the range we have defined. So we are doing good. We're not doing better. We're not doing worse. We are doing good.
And where do you get the range for what's acceptable? Are this some kind of external guideline, or is it history?
Yeah, it's history. It's literature. It's
oh, okay.
Yeah.
So compared to the organization's historical performance, and also evidence-based guidelines or something?
Evidence-based guidelines, yes.
Okay.
Yes.
What is the savings based on? History or some other measure?
Based on history. Well, that's a problem also. It's a challenge because we took the data from 2016 to determine the bundle. But we didn't have enough sight on innovations during the years which were coming. So we have intra-arterial thrombectomy. It's a new treatment for stroke, and it wasn't in place in 2016, but it's an expensive treatment. So we didn't take that in account in determining the bundle. And now in 2021, we use a lot of that IAT treatment.
And so all of the costs are based on 2016?
Yeah.
Is there any process for updating that over time?
Yeah, we're updating it with a few percentages each year, but that's not enough. Yeah, inflation. The problem with that is it's a very good treatment. Patients are going a lot earlier back home. They don't need more treatment in the rehabilitation center, but we don't have the data from the community. So patients are having that treatment are discharged to home earlier than they were in the past with other treatments. But we don't know if they consume healthcare in the community because we don't have the data. So maybe it's valuable and valid to have that treatment, and maybe it's valid to use more money from the bundle, but we only have the bundle for the clinical phase.
You mentioned that you'll be expanding the bundle to the community in the future. When is that anticipated?
I guess about 2022, so January 2022. So we need to make a new contract in December.
So the home nursing or community resources will be reporting something and sharing in the funds.
Yes. And then hopefully we have more healthcare insurers involved, because we now have only one healthcare insurer. It's a big one in the Rotterdam area, but there are also other big healthcare insurers.
I know anytime you need to get different groups professionally to work together, that can be challenging. Doctors and nurses, doctors and hospital administration, the rehab center, the hospital specialists. What were the keys for you to success in developing this model? Who were the key stakeholders or groups that you needed at the table to develop a model that they would all buy into and be happy with?
We had a lot of stakeholders, so the CEOs from the nursing home and from the rehabilitation centers, CEO from the hospital. That were some groups, people from the healthcare insurer, but also the doctors, the MDs, other healthcare professionals, people from sales, so the ones from the money. that sort of people. So everyone involved in the healthcare system around the stroke patient.
And you mentioned the leadership, CEOs, and are they mostly not physicians?
Not physicians.
In Dutch rehab and hospitals, okay. Yeah. What about all the other maybe allied health professionals like physio and physical therapy, occupational therapy that's so important with stroke rehab?
Yeah, we needed them. because we needed to define the database. So all the variables in the database, they needed to be defined by all the healthcare professionals who worked with that, so who worked with the patient.
So who represents them? Just the CEO of a rehab center, or do they have like a
No,
industry
the professionals themselves were involved in that.
Okay.
Yeah.
Okay.
So I have a big contact list because, as I mentioned, from 1997 we're working together in the Rotterdam Stroke Service. So we have a lot of stakeholders and we have a lot of people working around, knowing each other. So we needed them to develop the project because they were the ones who needed to work with it.
What about, you mentioned the payers and all the different provider entities. What about patient advocacy groups or community advocacy, senior advocacy? Is that a thing?
Yeah, I'm sorry, we didn't involve them a lot in the process. Okay. Yeah, I think it is a challenge to involve them because a lot of stroke patients really have a lot of physical complaints, troubles, not always able to help us, to talk to us. We have also informal caregivers, but we try to involve them and we try to speak with them. Some spokesmen from them we have involved, but not really in depth, not in all the processes of developing.
I think that's everyone. The patient experience idea is really new since 2016. I mean, very few people were doing very much in that area now. I'm wondering, as you expand into the community with the bundle, will that become more important?
Yeah, we use prompts.
Okay, great. So evaluation. You've said that you felt like the quality is held stable or maybe the cost. Can you elaborate on cost, quality, how that has changed over the last 5 years since implementation?
Healthcare costs increased, so we saw that from the data. It really increased. Quality stayed the same. We have a lot of evaluation processes around this project with all the stakeholders. We talk about how did we do it, what challenges we had, and I mentioned a lot of the challenges we had. Those are the subjects we talked about in those evaluation procedures.
Now, healthcare costs are always rising. Did costs for the network, for the system, rise more than in the general healthcare costs? Or I'm trying to get an idea whether it was any worse than normal medical cost inflation.
No, I think it increased more than expected. Yeah.
So why do this at all? If the outcomes are the same as before and it costs more money, well, why do it?
Yeah, I think because we want to change the system, because we think the system as it is arranged now, it's not sufficient, because it's too complicated. And in this path we learned a lot about how to do it and how to not do it. I think it will help us to make a better system. At this point, it's not the best, but we need to learn.
And of course, that's the most uncomfortable time, is that learning period when you're trying to figure out what works and what doesn't work. Yeah. What about the personnel? We haven't talked a lot about your clinicians, therapists. How do they feel about the new model, or is their life unchanged?
Their life is unchanged.
Okay.
Yeah.
It really was behind the wall with the finances.
I called it sometimes the toy of the professors, the toys of the CEOs, or the toy from the policymakers. Yeah, they just do their work, professionals. They just do what they need to do for the patient, and they don't really care about money.
Sure. Yeah, they care a lot about their patients and outcomes.
Yeah, but not about the money. They don't care about it.
Perhaps that's how it should be.
I think so.
Perhaps they should be focused on the patients. If I was their patient, I hope they would be focused on me. So I think that would bring that around to the end, which is, what is your advice for other people? You're on the forefront of learning in this space, bringing value-based care to the stroke aspect of chronic conditions. And you know, in multiple countries, multiple organizations, people usually start looking at chronic conditions as one of the first areas to do value-based care. So what's your advice for others who want to learn from you in other countries or other organizations how to do this to get the most impact on outcomes, quality, maybe employees, patient experience, and cost?
The most important, I think, just go on that path. Try to learn, use innovations, talk to other people. Don't hesitate to try something. You cannot change the world by sitting and don't do anything. You cannot change the world if you do nothing.
What have you all put in place as a team to learn as you go? Like, are there maybe quarterly or monthly times of reflection to see what we've learned and make changes?
Yeah, we have those evaluations.
Talk about that. That's important for all of us.
Yeah, we have quarterly evaluations with all parties, with all stakeholders, about indicators, about the database, about the data, about costs, about the bundle, about everything involved in the project. We have quarterly evaluations or even weekly evaluations with the different stakeholders. Sometimes we have a quarterly evaluation with a lot of stakeholders, for example, with 20 persons at the same time. But yesterday I had a meeting with someone from the hospital, and we had all the financial data, and we went into all the financial data to make something of it.
So can you give an example, just to bring that idea to life, where you dove into the data, maybe one-on-one or maybe with a big group, and you found, here's a lesson we just learned, good or bad, how you did something with that, like a PDSA cycle or something. How did you learn from that?
Well, for example, we followed a few patients through the complete process from clinical rehabilitation, from hospital to the rehabilitation center, and what did they cost in the hospital and what did they cost in the rehabilitation center, and is that normal? Or, for example, we saw a patient which costed about 100,000 euros. So we have a bundle of 22,000 euros. So that we thought, okay, what happened there? So we try to figure out why patients cost 100,000 euros and why patients, for example, cost 3,000 euros in the clinical phase. And we do that by following the patient's journey, talk to the medical specialist, talk to the patient. We have intern, Lieke is her name. For the coming half years, he is looking into that data, into the patient journeys. So why did we do that and why we didn't do that? And we look at 15 patients. We have a selection of 15 patients.
Now, it might be that you didn't do anything wrong, that there was something fundamentally higher risk about that patient. Is there risk adjustment is something I know we've been talking about a lot as I meet with other people talking about value. Is it 22,000 euros for every patient? That's just the norm? Or is there a way to adjust up or down to account for the realities of the patient's risk profile?
Yeah, we need to figure that out. Because now it's 22,000 per patient. So we have in our project, we have about 100 patients. So 22,000. So there's not an adjustment at this moment, but for the new contract, we have an adjustment. We need to have an adjustment.
Sure. Yeah, some of that risk is nothing you can affect.
Yeah.
So it's important to know.
Yeah.
Right. One of the last things I wanted to talk about, again, with regard to your advice for those who come after you. What are key things that if they fail to do them, the program will not succeed? Maybe whether it's about design, incorporating particular voices, or other design aspects. What are things, if they don't do them, they'll fail? Investment
in relationships. That's key. Investment in relationships. That's really key. If you don't know each other, if you don't meet each other, if you don't like each other, you're gonna fail.
How did you do this successfully in your group?
That's in the Rotterdam Stroke Service. I always bring cakes. I always bring lunches. I always bring chocolates. So it's a little investment in relations. I send postcards. I give colleagues presents. I organize symposia and just like having a gift, giving them a gift, a symposia with nice food. And they all enjoy to learn at the symposium and to network with each other and to have nice food. It's like a little bit of spoiling them. And now during COVID, it was difficult because I couldn't give them online chocolate or something. And on the other side, COVID brought us online meetings. And that was also beneficial because if you look at how we work in the Netherlands, sometimes you need to drive for an hour or an hour and a half. And it consumes a lot of your time to sit in the car for a 1 hour meeting. And online meetings helped us to see each other a little bit more. So we made the best of it during COVID.
So since you opened the COVID door, I'm glad you did. Okay. So I'm hearing you say that now maybe even relationships and our working with each other will be even better because we'll get back to doing the face-to-face we always did, but now it's enhanced even with the online. Yes. Any other things we've learned from the pandemic that will make the stroke collaborative better?
Yes, because in the first lockdown in March last year, March 2020, we had a lockdown and there was no healthcare available for the stroke patients in the community. So they couldn't rehabilitate in the community. There were no physiotherapists allowed, no occupational therapists allowed to come to the patients at home. First lockdown, we saw about 15% less stroke patients in the hospital. That was really strange because we knew that there were stroke patients. Where did they went? They went nowhere. They stayed at home, afraid of going to the hospital, afraid of calling the ambulance. I have a stroke. So they stayed at home. A lot of patients died because of that. They died at home because they were not treated in the hospital. And after that, we saw, of course, less patients in rehabilitation because some patients went to the hospital and said, I'm not going to rehabilitation, I'm going home because I don't want to be in a rehabilitation center. I don't want to get COVID. So they went home. Their functional status was really low. They really needed rehabilitation, but they were at home. And we needed to find a way to find those patients at home and treat them with rehabilitation. And in the Rotterdam area, we have a methodology of nursing, stroke nurses, and they visit the patients at home, always. We had that methodology in place before COVID. And I had several meetings a week with those 10 nurses, online meetings, to discuss all the patients who were in trouble at home and how to visit them, because those 10 nurses could visit the patients in their homes. They were allowed to visit those patients. So physical therapists were not allowed to go to the patients, but the 10 nurses, the stroke care nurses, were allowed to go to the patients.
Why? What was the difference?
Yeah, we don't know.
Oh, okay.
No, nobody knows. I think it's the same in the United States. We did something and we tried something and we had a lockdown and we didn't know why or what or how. And we went on a path, and with the lessons learned, we had another lockdown and we did it in another way. Yeah. So it was a crisis. I cannot blame anyone.
Yeah. Oh, I wanted to circle back to one question. You talked a little bit about information sharing. And what I interpreted you as saying that you couldn't share any financial information, but what about patient charts? Those flow from hospital to rehab to home nursing, right? Has that had any change in sharing the clinical data after the implementation of the network?
Yeah, because we had those Dutch health data providing us with a dashboard. So we could follow the patient journey with all the variables in it. So that is one thing we can share now with each other, because it's
anonymous.
Anonymous, yes.
Yeah, or de-identified.
Yeah, de-identified, yes.
So that's for the data as far as reporting, but does a paper, since they're not on the same electronic medical record, does a paper chart go with the patient from office to office?
Yeah,
okay.
for the handover, yeah.
Okay,
yeah.
Great.
A handover from nurses to nurses in the other facility, handover from medical specialists from one facility to the other. We don't have electronically patient records for the whole system. So every facility has its own electronic system.
Yeah.
and it's not connected. Unfortunately, yeah.
Well, thank you so much. This has been a great learning experience, not only for me, but for, I know, a lot of people who will watch the video and read the research, because stroke is an increasing issue around the world.
It is.
Not only here at all. It's certainly a big issue in the U.S. and probably all the other developed and developing countries around the world. So it's great that we learn what you all are doing to experiment, learn, improve care, think about aligning financial incentives, etc., so that we can, in the end, really improve the health of our population. So thank you so much.
Okay, thank you also.